Hello and welcome to the next ASGBI East Midlands Journal Club. I'm Jazz, I'm one of the CT1s in general surgery currently based in Nottingham. Today we'll be discussing the paper entitled Preoperative Intravenous Iron to Treat Anemia Before Major Abdominal Surgery, also entitled the PREVENTT trial. It was published online on the 4th of September 2020 in The Lancet, which has a huge impact factor of 60.392 as per data from 2019. Multiple centres were included internationally and across the UK, as you can see from the slide. Now, starting with the introduction, they outlined the current NICE guidance, which suggests that any patient with iron deficiency anemia tends to have poor postoperative outcomes. And by identifying this early and treating them preoperatively with either oral or IV iron supplements, it can reduce the need later for a blood transfusion. Any patient with an expected blood loss of more than 500 mils in their operation should be screened 2 weeks preoperatively. And this is how the IV iron pathway first came about, to optimize patients, especially those with colorectal cancer, to reduce their operative outcomes and reduce post-operative complications. So they aim to look at the clinical effectiveness of IV iron against a placebo. In this case, they used normal saline, and they hypothesized that IV iron would reign superior over the use of a placebo in two main factors: one, reducing the need for a blood transfusion, and two, deaths. So 46 centres across the UK took part in a double-blinded, parallel-grouped, randomised control trial. Now, for inclusion criteria, it was any patient over the age of 18 undergoing an elective major open abdominal surgery, which they defined as any operation lasting longer than an hour for benign or malignant disease. Their screening hemoglobin for females was set between a hemoglobin of 90 and 120, and in men was set between a hemoglobin of 90 and 130. They identified patients between 10 to 42 days before their planned operation. Now, there's a whole list of exclusion criteria. I'm not going to go through all of them, but the ones I wanted to highlight was patients undergoing laparoscopic surgery were excluded, and patients who had previously had EPO or IV iron in the last 3 months, as well as this whole list of comorbidities. Randomization was done using a secure web-based service on the London School of Hygiene and Tropical Medicine website. Now, one thing to note was that the colour of IV iron and their placebo was very different. So this was identified, and black tubing was used to maintain double blinding. So in terms of outcomes, they had two sets of outcomes. They had two primary outcomes, which was the need for a blood transfusion, which they defined as being a unit of packed red blood cells or any other blood component, and death. And their secondary outcomes included total number of red blood cells or blood components transfused at 30 days or at 6 months, change in hemoglobin concentration to the day of surgery at 8 weeks and at 6 months, any postoperative complications, ITU stay, total length of hospital stay, mortality, and health-related quality of life questionnaires, which was done preoperatively and at follow-up. So 487 participants were included from across all these 46 centres between January of 2014 and September of 2018. Some patients withdrew, were lost to follow-up, and died, so were removed, leaving 237 patients in each group. So looking through some of the results, a whole list of demographics were included and preoperative factors. One thing I wanted to highlight here was the type of operation was left very general and specialty specific. Looking through more of their data and tables, so as we would have expected, hemoglobin concentrations for patients preoperatively, so on the day of surgery, improved with the use of IV iron, and readmission rates for complications actually was better in the IV iron group. Now, relating back to their two primary outcomes, patients in the IV iron group, 105 of them needed a blood transfusion and 111 needed a blood transfusion in the placebo group. And in terms of deaths, there were 67 deaths in the placebo group and 69 deaths in the IV iron group. So they concluded that their trial showed no difference between using IV iron and the placebo when given to patients between 10 to 42 days before their planned operation. Now, they did note that one of their own limitations was that they didn't actually define what they meant by iron deficiency anemia and didn't include that as part of the inclusion criteria. So just some of my thoughts on the paper. I wanted to highlight the inclusion criteria to start with. So they defined a major surgery as an anticipated duration of longer than an hour. So I did some research and found their previous inclusion criteria. This was rejigged several times before the final copy. So previously they had included a whole range of operations to include. Now, it would have been nice to see this broken down a little further rather than leaving it so broad as being specialty specific, as that would have been quite interesting to see. Additionally, on this slide, they identified patients with a hemoglobin between 90 and 120 or 90 and 130 in men. Now, in most centres, a blood transfusion isn't given until the hemoglobin hits 70 or below, or if the patient is symptomatic. So a whole range of patients were actually missed with a hemoglobin of less than 90. So any future studies, including patients with hemoglobins of less than 90, would be quite interesting data to look through. Additionally, as a limitation that they mentioned themselves, they haven't included any iron studies or ferritin as part of their inclusion criteria when they are specifically looking at patients with iron deficiency anemia. Now, indications for operations included both benign or malignant disease. Now, it would have been interesting to see this broken down a little further, to see benign versus malignant disease and seeing outcomes in both of those groups, and breaking down malignant disease further. As we know, the IV iron pathway exists for colorectal cancer patients, so seeing the direct correlation of giving IV iron to then requiring a blood transfusion in that limited set of patients would have been quite beneficial. So 487 participants were included from all of these centres in the span of 4 years. That works out to just over 10 patients per centre in this 4-year span, which suggests quite a limited uptake, and one could question why this is. In terms of primary outcomes, so one of their primary outcomes was the need for a blood transfusion. Now, they defined this as either being 1 unit of packed red blood cells or any other blood component. Now, it's only packed red blood cells that would actually treat an anemic patient. Any other blood component wouldn't quite do the same thing. So again, it would be quite nice to see this broken down a little further to directly correlate IV iron to actually needing packed red blood cells at a later date during follow-up. So upon doing some further research, I have found a whole variety of studies that do confirm that giving preoperative IV iron therapy can lead to improved outcomes, specifically in colorectal cancer patients, as this is what the pathway currently exists for. And to finally mention prehabilitation, so patients who are symptomatic with their anemia and could benefit from exercise therapy preoperatively, IV iron would still have a huge benefit in these patients, as not only would they provide symptom control, they would improve exercise tolerance and optimizing their care in the perioperative and postoperative stage. So that's just some of my thoughts on the paper, and I have many more, as I'm sure you all do too. So I'd love it if you could continue the discussion on the ASGBI East Midlands Journal Club web page on Twitter. Thank you.